So thing to understand from this slide is remember that your cancer cells have ligands on the surface such as PD-L1, CTLA4, and then your immune system has the ligands as well. In order for your body to activate the immune system and those are the activating signals. In order for your body to activate the signals and have immune attack to kill your cancer, you want to use what we call immune checkpoint blockers, breaks that can attach to the surface ligand and do not allow the cancer cell to make it sound that cancer cell is one of our own body cell, and so overcome that inhibitors. And I will,
I have a question, if you would.
yes.
Does the degree of expression of the PD-1 or PD-L1 affect the response rate to immunotherapy or no?
Sure, it varies from one cancer to another type. For some cancers, like you will see, I will talk about lung cancer or a head and neck cancer, PD-L1 expression does matter, and that is one of the things that you consider when you can do only immunotherapy versus chemotherapy and immunotherapy, for example. But for melanoma, we do not check it often because regardless, even patients, if they have PD-L1 score of 0, they respond to immunotherapy. And the bottom line is for that, if you look at PD-L1 is one on your tumor cells, but there can have other markers as well which play a role that your response to immunotherapy. For general knowledge, yes, you're right. PD-L1, when you have high PD-L1, you are high likelihood of response, but remember that it varies from cancer to cancer, and even for some cancers, if you do have PD-L1 score of 0%, you can still respond to immunotherapy.
Thank you so much.
Sure. So, and then names recognized with maps, when you see those, remember those are immunotherapy agents. So imagine if you activate your immune system starts attacking not only the cancer cell, but it starts attacking your own body other cells. And nowadays there are so many lectures for ER resident, for internal medicine resident, because these, and obviously you, wherever you go, you can fit in this slide to you. You're a cardiologist, you're an endocrinologist, you're a pulmonologist, you're a gastroenterologist, you're a rheumatologist. You can fit in this slide to you because you need to know these agents. You will eventually come across to these agents. And obviously in internal medicine, you are a first person when patients are admitted and have a question. So just think about that. When you activate your immune system, it starts attacking not only cancer, but it attacks also your own body cells, and you can develop various itis, various inflammation. I can just, you can see on the slide, you can fit in any place like pancreatitis, perforation, colonic perforation. So it, like you can see, myasthenia gravis like syndrome, and those are real. Like I have seen a lot of those. So, and you have questions in Mixup and you have questions in boards, and real life you will for sure count this. This is a little bit busy slide. It's a good one to show, especially for one who's interested in rheumatology, that there are different mechanisms that really underlie the development of like adverse effects, what we call immune-related adverse effects, for you to remember for boards and for your clinical practice. When someone comes, remember, number one, you need to remember corticosteroids. You need to remember that you start high dose steroid. This is not a dose for COPD exacerbation. So you have to start 1 to 2 milligram per kg daily systemic steroids. Very interesting, you have to taper those very slowly, because it has been shown if you taper those quickly, even your patient has no symptoms, there is a high likelihood that it will start creeping up. And then you will need to consider the consult organ specialist if you have a concern. Such situation will be when cancer patients come to Sparrow Hospital ED. Patient is on one of those drugs that you need to recognize. And then a patient reports having any of those symptoms, like having diarrhea, if this is a colitis, having difficulty breathing, if this is a pneumonitis, and etc. So you need to recognize those, perform proper diagnostic workup, and consider high dose steroids, oncology consult, and an organ specialist consult, which will be pulmonologist or gastroenterologist. I have questions. I got these questions from like Mixep. I got the question from internal medicine. Those are poor internal medicine questions. So you really will get those questions in the board. So I'm fine if you guys want me to read, if you want to read, whatever you prefer. It might be more interactive if you read, but that's fine, whatever you decide.
We can.
Yeah, I can go ahead.
Yeah.
Okay. So a 28-year-old male with metastatic melanoma who is on systemic therapy with ipilimumab 3 mg per kg and nivolumab 1 mg per kg presents with an abdominal pain, cramping, and bloody diarrhea. What is the next step in management of this patient? Admit, start 1 mg per kg methylprednisolone and consult GI for scope. Outpatient PO prednisone 40 mg daily for 5 days. Infliximab 5 mg per kg. Antibiotics, scheduled and BRN antidiarrheal agents. Yeah, I think I will go with A. We were just talking about steroids. These patients will need high dose steroids and consult for an organ specialist.
Absolutely, you're absolutely correct. And this question highlights that you realize that ipilimumab is immunotherapy. You realize that you need to do high dose steroid rather than a COPD, prednisone of 40. And you realize that you need a diagnostic workup. And usually when you do a scope, there is a picture of like IBD. Like if any of you are interested in GI, you would see similar like lymphocytic infiltrate, and when you do the scope for this patient. And this is important because you will definitely diagnose the patient having a side effect. Usually there are grading system, like depending on the grade, like from how bad is that, but I don't think board will ask you, and I don't think you really need to go in details, but general idea to understand that, hey, this person is on immunotherapy, this is what the board wants you. And usually next step, if someone doesn't respond to steroids, you could go to the infliximab, anti-TNF alpha inhibitor. For your boards, you need to know infliximab, like for TB testing. I think they might ask you for another scenario, just to understand that you wouldn't just do antidiarrheal therapy, or you would not do the antibiotic. You need to realize that this is a person on immunotherapy. So next question.
But for that patient, after you give the steroids, once diarrhea is resolved, you can restart the immunotherapy after.
It depends. Yes, that is correct, Mark. It depends what grade is that. Usually you wouldn't challenge the grade 4. Like grade 4 is someone like can come with colonic perforation. Like I have patients come with perforated colon, that probably you would not challenge. But otherwise, if you have a colitis, you treat it, you finish the 4 to 6 weeks of steroids, patient is well, yes, you can re-challenge them.
Thank you.
Lilith, I have a question, if you would.
Yes.
In clinical practice, I know this is just a question, but in clinical practice, if someone comes with bloody diarrhea, are you worried to rule out if there's an infection before you start steroids, even if you know they're on immunotherapy, or do you just start steroids right away?
Absolutely good question. You're right. You need to, I probably really tend to do important thing. You're right. You first to do like a diagnostic workup. You do your CD. In general, when you see someone with oncology patient on chemotherapy, immunotherapy, anything, have a low threshold of checking CD. So do the CD, do all like all your infectious workup. You're absolutely correct. And then if once those are negative, start the steroid.
Thank you.
So next question.
Bennett, I have a question, please. So immunotherapy, do they suppress the immune system and make you like more susceptible to infections? Like, does all of them suppress the immune system in general?
No, actually, it activates your immune system, and that's not that you become suspicious to the infections. Indeed, like when you use chemotherapy, you become neutropenic. That's what makes you suspicious for infection, but that's not the case usually with immunotherapy. So next question.
I can read this one.
Mm-hmm.
65-year-old male with stage 4 lung adenocarcinoma who's on pembrolizumab presents with shortness of breath, SpO2 90% on room air. What's the next step in management of this patient? So I think it's similar to this: high dose steroids, 1 milligram per kg prednisone, order stat CT chest, and consult pulm for bronch.
Sure, absolutely correct. Again, your scenario and a down picture. Actually, I took this picture from one of the pulmonary journals. So just to highlight that this is really, you will come across to these questions. Like number A is like when patient started the pembrolizumab. And then B is after starting the pembrolizumab, patient presents with difficulty breathing. You do the CT chest. Tend to do a CT chest. You can do without contrast, so really no limitation. You don't use a chest X-ray, like it will not show a lot. And then B, patient was started on antibiotics wrongly, and you will see that patient has now more infiltrates. And then D, patient after steroids. So it's a classical picture, like see someone with pneumonitis. And infliximab will be the next line therapy you could use. Remember, infliximab is a hepatotoxic. Like if you have someone developing hepatitis due to drugs, bad immunotherapy drugs, you would not use infliximab because infliximab is hepatotoxic. So I think those are like highlights from immunotherapy. I will come across immunotherapy agents again, but just to remember, you can develop rash. All cardiac actually is very fatal complication, myocarditis, and it happens in 1% of patients, but patient can die, so you have to be really aggressive with management of that. So next I will proceed with sort of focusing on three cancer types: melanoma, head and neck, and lung cancer. And all those questions are from your mix-up, so really relevant, trust me. So melanoma is a skin cancer, at least the cutaneous melanoma. You can see melanoma in other parts of your body, like in colon, in like those are different types of melanomas. Those are called mucosal. I don't think that's relevant to this talk. So we are going to focus on cutaneous melanoma, skin melanoma. And your mix-up has questions about how to manage stage 1, 2 melanoma and the stage 3 melanoma. These questions are in your mix-up. So basically, remember, if you have a lymph node involvement in patient with melanoma, it is stage 3 disease. And if you do not have lymph node involvement, it is stage 1 or 2. You will not be asked usually about separate management of 1 or 2, which shares similarities. What you will be asked, how do you manage stage 1 and 2 disease, is basically you are going to reach someone who does not have a lymph node involvement. Remember, you will have to do wide local excision. Wide local excision is mainly depends on a thickness of melanoma. It's like, just remember, it's called wide because it is not like based on a thickness of melanoma. Like if you have like more than 2 millimeter of melanoma thickness, your excision margin should be 2 centimeters. Just kind of have idea what is wide local excision. For melanomas which have thickness of 0.8 millimeter and more, you will need to do sentinel lymph node biopsy. What sentinel lymph node biopsy is, you have a dye which goes from that melanoma to the lymph node. And then you sample, you take out that lymph node and you look under the microscope to see even your patient doesn't have palpable lymph node, or on a CT scan, you still can have a sentinel lymph node, meaning the lymph node that is draining that particular melanoma. And examine if, imagine why you would do this, because if you have a lymph node involvement, that upgrades you to the stage 3, and that changes your whole management. If you look at this curve, you will see that what is very important is the thickness, is the depth of a melanoma, because depending how deep is your melanoma, you will see that the survival really goes low. This is about the same breast flow thickness, it's about the depth of the melanoma. Just remember that more thicker the melanoma is, it is high likelihood that it will go to the lymph node. Here is why if it's more than 0.8 millimeter, you should do the lymph node sampling. And much more thicker melanomas have a higher recurrence. So melanoma specific survival probability really varies. If you see from T is like a thickness, it's based on a thickness and an ulceration. But what you need to remember is about the thickness, because you have a test about that. Regarding stage 3 melanoma, when you have someone with lymph node involvement, in addition to doing this wide local excision and the lymph node, you have to do adjuvant therapy. Adjuvant means therapy after the surgery, which aims to prevent the disease coming back. That's what adjuvant means. And the 2 types of treatment you can do in this case. One is immunotherapy, anti-PD-1 immunotherapy. We had those names, pembrolizumab, nivolumab, or in cancer world, you will see that patients, when they have a cancer, they have different mutations, different changes in the cancer that actually is the major driver of that cancer. In melanoma world, it's about the BRAF, and you have a test about this. When you can use targeted agents which actually target this BRAF in order to treat your melanoma in the adjuvant setting. It is a lot of information. Now we will go over each test, and like I will show you that these are real tests from your mix-up, and you will remember the information. So who wants to read this test?
I can do it.
Mm-hmm.
A 50-year-old man is evaluated for a firm, darkly pigmented papule on his back that has been growing steadily over a period of several months. The skin lesion is 0.5 centimeter, darkly pigmented raised plaque with irregular borders and inconsistent coloration. A skin biopsy is performed and shows malignant melanoma on pathological examination. Which of the following is the primary feature used to determine the prognosis? So it's lesion depth.
That's correct. So you're absolutely correct. See, if we go back, this is the answer. So you see that much thicker melanomas, they have a low probability of melanoma specific survival. Absolutely correct. So this is a mix-up question. Next question.
I can do that. A 38-year-old man is evaluated for a pigmented lesion on his upper left back. A 1.8 centimeter irregular, dark, pigmented, slightly raised papule with irregular borders is present on his upper back. There are no adjacent lesions and no associated lymphadenopathy. Skin biopsy shows malignant melanoma, superficial spreading type and measuring 1.4 millimeter in thickness, with invasion into the reticular dermis but not into the subcutaneous tissue. There is evidence of a vertical growth phase. Which of the following is the most appropriate next step in management? Based on the size and the thickness, he needs a sentinel lymph node biopsy, and definitely he needs like wide local excision. So I think it's C.
Absolutely correct. You're right. So see, we go back, we read about this. It's a thickness of more than 0.8 millimeter. You have to do the excision and you have to do the biopsy. And this is again a mix-up test. So trust me, I don't say anything more than you really need to know. So you're absolutely correct. Good. And let me see if I have, okay, I do have that test. I do want to show you this slide for your general knowledge. So this is about the metastatic melanoma. When the melanoma has spread from original site to other parts of your body. And you will see from 1974 to 2020, there have been major advancement in the melanoma field. And if you look at these drugs, you do not have to remember the name. But one thing I would like to highlight that you will see in your boards, look at these INIB drops. Do you see dabrafenib, trametinib, vemurafenib, cobimetinib, and encorafenib, INIB drugs? This is how I recommend you to remember INIB drugs. These are BRAF/MEK targeted drugs. And if you come across to the test in your boards, if that asks you, it is BRAF mutated, there is a BRAF mutation present. So you could choose one of those drugs. I think Mixep has one of those drugs but you could also choose immunotherapy. Now we do not know if those patients actually receive targeted therapy or immunotherapy, which one is better. So you have both choices you can choose. And again, for your highlights, you have nivolumab, pembrolizumab, ipilimumab. You do not have to remember the names, but just when you come across with something like this, you know these are immunotherapy agent. And if boards ask you about management of melanoma, it is never chemotherapy. It is always either these agents, BRAF/MEK, or it is about the immunotherapy. And pay attention that you have to check this BRAF status. When you have a melanoma that it is in stage 3, or is it stage 4, which means cancer is out, or stage 3, which means lymph node involvement, you have to check BRAF mutational status. Why? Because it's a predictive biomarker. It tells you if you could use those drugs or not. So this I want to show you because you may hear sometime this is a very interesting concept in oncology, or just you may not probably get that as a question in a board. But just to show you, if you look a lot of articles on Kaplan-Meier curves, one thing you would see as a difference when do you see how like these curves just flattened out, flatten? They do not drop, they flatten. That's some like might have been one something, but do you see for long duration a flat curve? This is very unique characteristics of patients with melanoma. I apologize, with immunotherapy. What they common use the terminology is tail of the curve. The tail of the curve that matters a lot, because if patients respond to immunotherapy, they tend to respond for a long time. So you would see that if someone falls in this category, comes to your clinic or your primary care provider, you shouldn't be surprised. Someone with stage 4 disease who, for example, has been treated with immunotherapy and falls in this category that responded, you will see that a long time, this is like for 5 years of follow-up, like this patient just live, they are almost cured, like they are 5 years out from their stage 4 disease. So this is just general knowledge of this, that with immunotherapy, in contrast to chemotherapy or targeted sometimes, you see people who respond, even if someone comes to your medicine clinic, cancer patient on immunotherapy, you need to acknowledge that, yes, this patient may have a long survival, even though patient has a stage 4 disease. And what they call in the world of oncology is like tail of the curve, meaning that like it just goes. You responded, you go for a long time. So next question, if anyone wants to read.
I can
Read it.
Oh, okay.
So a 62-year-old man is evaluated for a 1-month history of nausea, anorexia, and a 4.5 kilogram weight loss. A superficial spreading melanoma of the left thigh, 2.2 millimeters, with one positive sentinel lymph node, was diagnosed 1 year ago. The patient declined adjuvant interferon alpha therapy. CT scan of the abdomen and pelvis showed an enlarging liver with 5 hypodense lesions in both lobes, measuring up to 2.5 centimeters that are consistent with metastasis. Ultrasound-guided liver biopsy showed metastatic melanoma. Which of the following is the appropriate next step of management? So as you were talking, probably BRAF mutational analysis to see.
Absolutely correct. Absolutely. So you're right. You have to do the mutational analysis because 50% of cutaneous melanoma, like a half of the patients, harbor this mutation. And this is a predictive marker which will guide your treatment option. You're absolutely correct. From this test, I want to highlight one thing. Whenever you see a test that asks you, like, patient has liver metastases or lung metastases, what is the next step? Let's assume you have a test, and you do have a test in the mix-up, but doesn't have this sentence, like we cross this sentence. It will ask you, what is the next step? Next step is always a biopsy, because in oncology world, we say no tissue, no issue. So if you don't have the biopsy, you do not have a diagnosis, you really can't treat that patient. So every time when the board asks you, patient has this, and patient has lung lesions, liver lesions, and what is your next step? Your next step is going to be a diagnostic workup biopsy. How do you choose what site to biopsy? It will ask you, patient has like a lung lesion, liver lesion. Remember to biopsy the one that you think is a metastasis. For example, it will tell you patient with like a 50-pack or smoker with multiple lung nodules, liver nodules. Like, you think about that, this is probably lung cancer travel to liver. So let me get the liver, because liver will tell you, number one, what is the diagnosis, but number two, it will tell you that this is a stage 4 cancer because it's already spread from the original site to the liver. Otherwise, you will remain with a question, is this liver a fatty liver or whatever, or this is a cancer? So board will ask you, what is your next step? The only time that there is a question in a mix-up, it will give you a very good description of the hepatocellular carcinoma, HCC. It has a very, very discrete patterns on the MRI finding, and will tell you what to do next. In that only time for the boards, in real life it might be different. You would choose treat as liver cancer. You would not choose biopsy. Remember, only time is the hepatocellular cancer, which will give you a discrete MRI finding and will tell you to treat that. Otherwise, anytime it gives you some description, your next step is going to do a biopsy of the most metastatic site. Another thing I would like to point you for boards, a lot of times oncology questions in a board are very long, and this is the half of this question. I took this question from Mixed. For you to save your time, I recommend you to read the last sentence, and then I recommend you to read the question to see if you can actually answer this question without reading the rest of the part of the test. For example, if you read the last sentence, like showing metastatic melanoma, what is your next step? It is very easy to guess that this is going to be BRAF. This is to save you time, because what really matters in cancer patient, what is your diagnosis. Remember, there's a lot of other stuff like, yes, declined and other stuff, but there's a lot of matters what is your diagnosis, because oncology is a lot of times gives you the diagnosis and asks you to do the next step. It will be either additional imaging, diagnostic, or it will be a treatment. So trick to use, try to read the last sentence. And if you don't get a vibe what the question is and the answers, go back and read the whole question. So let's move to the lung cancer. Yes?
Quick question, please.
Yeah.
You mentioned like taking biopsies from like even the metastatic lesions. So if you have like a colon cancer patient with multiple liver lesions, he's diagnosed with colon cancer, but you still don't know like if the liver lesions are most likely metastasis, but we're not sure. Do you still get a biopsy from that, or you would just assume that it's a metastasis from the colon?
Sure. If the patient has a new diagnosis of colon cancer, like presents with colon mass and has a liver, I would target the liver for diagnostic workup. Like I would do the liver biopsy to understand what is this. However, if someone has a colon cancer, has a lung metastasis, and then it gets treatment, and then has now comes with new liver disease, new findings. If I'm very suspicious that this is just a disease progression, rather than I would not do additional biopsy. But if this is my first patient comes to your clinic and this is completely new, I would target the metastatic side rather than a primary side.
Okay, thank you.
Did that answer to your question?
Thank you.
So now a little bit about lung cancer. So lung cancer, so early stages like stage 1 to 3. NSCLC is basically non-small cell lung cancer. When you see a lung cancer patient, think about non-small cell or a small cell. This is the general idea of classification, just because remember, small cell is bad, and small cell is almost 95%, 100% in male is related to smoking. So if someone has a small cell and never smoker, I question that diagnosis. So you probably need to look at that more. So any early stage, when you have stage 1 and 2, one lesion or a lymph node in the same lesion, you try to do the surgery and the chemotherapy, if like a radiation therapy, if it tells you that it has like lymph node involvement, positive margin, general sense, it tells you that there is some cancer left in the body. If you do have stage 3B disease, which you see that is not in a one side of the lymph node panel, it's like contralateral lymph node and a higher levels of lymph node like supraclavicular, you would need to do the chemotherapy with radiation therapy. This is generally not a cancer that you are going to take someone to surgery. Concurrent chemoradiation means that you do chemotherapy and radiation therapy together. And very famous study in lung cancer, you will see that patients with stage 3B disease receive chemotherapy and radiation therapy. And then after this followed with durvalumab. Durvalumab is again immunotherapy, remember this MAB. And they actually had a really improved recurrence-free survival. So that they had a better diagnosis. General, just remember, patient with non-small cell lung cancer, stage 3B disease, patient received chemoradiation, and patient will need immunotherapy. So again, what your board will ask, this is a busy slide, but I will walk you through this and I will highlight what the questions you have at the mix-up. Now, if someone has a non-small cell lung cancer, remember, those are two major subtypes, squamous cell and non-squamous cell, which is adenocarcinoma. Remember, board will ask you, someone came with adenocarcinoma, it fits in this category. Do you guys see this? It says EGFR, ALK, ROS. You don't have to remember those exact names, but the idea what you have to remember that if someone has a non-squamous cell adenocarcinoma, your next step will be to define if this cancer has driving mutations such as EGFR, why? Because this is another predictive biomarker. If that has mutations, you could treat with targeted agents again, which are INIB drugs. See, remember these INIBs like BRAF from melanoma? Lung cancer can have BRAF as well. Board will ask you, patient with lung adenocarcinoma presents, what is your next step? And they'll ask you, you have to choose, check for mutations like EGFR, ALK, ROS. You don't have to remember these mutations. I don't think they will check this, but they will ask, they will give you the names of mutations, but they will give you other options as well, like start the chemotherapy. That's not a good right answer. Right answer is to check first before we do. And if you look at this slide, you will see that if it's squamous cell, you do not check. See, this is the difference. If it's squamous cell, you do not. If it's a adenocarcinoma, like non-squamous cell, you do. And then board will ask you, will give you a picture of squamous cell patient, and then we'll ask you how to treat this patient. It will give you choices. And so it won't be, I don't think they will question you on this, but kind of going back to the one of the questions, very good question, like about PD-L1, you will see answer to your question here. If someone has a PD-L1 score of 50% or more, you could just use immunotherapy, single agent immunotherapy. Whereas if it's less than 50%, you would use combo rather than. And again, we go back here, you see if someone has a targeted agent, when you treated a targeted therapy, see, you do not go to immunotherapy or chemotherapy, you treat with a targeted. And board will ask you this question, it will ask you EGFR mutated, how do you treat this patient? INIB drugs, INIB. I don't think it will question you. Is it osimertinib in real world? Yes, it is. Or crizotinib or dabrafenib? No, it won't question you, but it will question you. Osimertinib, pembrolizumab. As long as you understand the different class of drugs, you're good. You don't have to remember the names.
Well, I have a quick question. So
yes.
For the PD-L1, it's going to be part of the biopsy. So the biopsy itself will tell you the PD-L1 like more than or less than 50%, while the other stuff you need to test for it, right? That's why you don't test in the squamous.
So everything you have to request additionally. When a pathologist gives you the diagnosis, you look at it, it just tells you what tissue is that. It will tell you biopsy is consistent with lung adenocarcinoma. When an oncologist will ask the pathologist to check for mutational, most pathologists, they would just proceed automatically because they know that they have to check, you don't even have to tell them. Okay. But this is the idea that when you get a biopsy, you will need to check those. And this is also important when you have a patient admitted to your service, internal medicine, and when you have someone getting just lung biopsy, patient will ask you, what is my prognosis? What is your answer? You cannot tell the prognosis. You know why? Because you don't know where does the patient fit. Because if patient can be on targeted therapy with stage 4 lung cancer for 3 years, without your answer will be, we don't know, because we have to run all those tests to tell you which category do you feel in.
Okay.
And opposite will be the small cell lung cancer. Remember, small cell is bad. Only in stage 1 disease, when you have only one lesion like less than 2 centimeter, you can do a surgery. Most likely board will give you like a 4 centimeter lesion, small cell. Surgery is almost the wrong answer for small cell. And then board will ask you about prophylactic cranial radiation if you have a limited stage small cell lung cancer, because it has an overall survival benefit. This is like someone has a small cell lung cancer, completed the radiation and chemotherapy, patient has no disease, no brain lesions. What is your next step? You have to do the cranial radiation because it improves the survival. And then an extensive stage, how do you differentiate? Like if it's a limited stage, you could do radiation. That's what you call limited stage. If it's to the degree that you cannot include everything in one area, it's called extensive stage. And remember, extensive stage is always bad. It has a survival like 12 months, median overall survival. So before the treatment used to be carboplatin etoposide, and then a few years back, atezolizumab immunotherapy was added, and it really made it was 10 months with these two drugs. Now it's 12 months, so not really a good. One thing is really important. If someone comes with lung cancer to the hospital, you do a biopsy, pathologist calls you and say it's a small cell. Your patient has a performance status of free. What a performance status of free means, let me just show you, this is another really important thing. It means that patient is really weak, like almost to the bed. See, this patient like really bad. And this is because of the cancer. Guess what you do? You have to treat this patient. This is a very unique thing about small cell lung cancer, because if the patient has the bad performance status because of the disease, we treat those patients inpatient. Like it has a good response, like 70% of the cases, cancer will shrink. Unfortunately, it comes back really early. But when it shrinks, people feel really good. You can actually get someone from hospital who comes to hospital is really weak, like in bed, really bad shape. You treat those patients. Here's why it is important when you have someone admitted to your service with a lung nodule, you do the biopsy. You have to wait at least to understand if this is small cell or non-small cell. And that you should get in a day. That shouldn't take a long time. So you should not discharge someone before at least know is this a small cell or non-small cell. And if it turns out to be non-small cell, you set up a follow-up, you discharge someone. But if it's a small cell, you consult the oncology, and oncologists, we do a lot of like in-house treatment for those patients, because patient is very weak because of this disease. You give at least one cycle, one day of a treatment. It's 3 days of treatment for one cycle, and they go home. So bottom line for you to remember, for boards and for reality, wait until you get the diagnosis of it's a small cell or non-small cell. If it's non-small cell, patient asks you, you can't answer because there are additional tests, and oncologists cannot answer. Do not call oncologists and ask what is this patient's prognosis, because we cannot tell that, because we have to run additional tests. But if it is a small cell, ask the oncologist, will this patient benefit from in-house chemo? Because patient may be really bad. You treat those patient one time, responds and goes home. It will still come back, but you give that person a chance to go home.
Leonard, I have a question, and it's regarding the previous slide about non-small cell lung cancer.
Yes.
So my understanding that here in this situation, you can use Pembro regardless of the PD-L1 status, right?
So you use pembrolizumab only if someone has a PD-L score more than 50%.
Okay.
You use combination chemotherapy like carboplatin, pemetrexed, pembro, if the patient has less than 50%.
Left 50%. Okay.
Okay.
Thank you.
Sure. Now question, because of the time, I will go over a question by myself, just save us a time. I will highlight why I picked this question. So there is a famous study by Tamara et al. In discussing about someone with stage 4 lung cancer, if it's a non-small cell lung cancer. Remember, you always have to, this is the story that tells you patient has a like stage 4 lung cancer, non-small cell, what you do. In the boards, it's almost always in right answer to pick comprehensive palliative care assessment, because everyone wants palliative care to be on board. It's just good. It helps with the improved survival. That study showed that it improved survival with patients with stage 4 lung cancer if you include palliative care. So if someone is diagnosed with stage 4 lung cancer, is at the hospital, remember, non-small cell. Non-small cell, you got the diagnosis, it says it is non-small cell, consult the palliative care. Our call them and said, we would like to set up this patient with you. And the reference is a very famous study in 2018, Tamar et al. So this is a board question. And I think almost always palliative care is a good answer, unless someone is really doing well and it doesn't make sense for you to pick that answer. So this is performance status. Just remember, it goes from 0 to 4, 5 is dead. When someone board will ask you, someone has 1, someone has 0, as versus someone has 3. If boards ask you about 1, board is going to want you to do further diagnostic workup, treat this patient. But if board is telling you someone has 3, think about board wants you to pick like hospice, palliative care. So it is important clue if you see ECOG performance status in the boards. Okay, so remember, 1 is really good. You're not going to pick hospice for this patient, or does not want you to answer hospice for this patient. And this one is a question about, remember I told you someone with a limited stage small cell lung cancer comes and asks you like, you have treated this patient. Remember, it says near complete resolution of mass, lymphadenopathy, everything is fine. What do you do next? Like surgical removal? No, this is stage 4 cancer. Chemotherapy, prophylactic cranial irradiation. That's what will be your answer for small cell. Remember, this is a board. This is from your mix-up. Another question will be, let me see. Okay, does anyone want to read this one? In a way that I recommended. Let's try to read the end, last sentence of the question.
Okay, so CT-guided transthoracic biopsy of the right upper loop mass shows adenocarcinoma. Which of the following the most appropriate management? So I suspect that this is adenocarcinoma, not a small cell lung cancer, and would do EGFR testing.
That's correct. See, you answered your question. So this is a trick you could really use with all questions. You're absolutely right. It tells you something, and then it wants you to do further diagnostic workup. You're absolutely correct, because you're not done with your cancer diagnosis. Good. And then if anyone wants to do this one.
I can do this one. So 55 years old woman undergoes follow-up evaluation for a recent diagnosis of lung cancer. Initial evaluation included a plain chest radiograph that showed a right middle loop mass confirmed as a 3 centimeters speculated mass on chest. CT, PET CT identified hypermetabolic uptake in the mass but was otherwise normal. On surgical resection, the tumor was identified as an intermediate grade adenocarcinoma with clear margins and was negative for molecular genetic abnormalities. 1 hilar lymph node was positive and 10 out of 10 mediastinal lymph nodes were negative for tumor. She has never smoked, medical history as otherwise negative, and she takes no medication. Which is the following is the most appropriate next step in management?
I think what it tries to tell you was negative for molecular genetic abnormalities.
So I think it would be radiation therapy. See?
One thing to consider in this case, it's a pretty large disease. Like, see, clear regulated mass, CT mass, but was otherwise negative. But, so it is adenocarcinoma. 1 hilar lymph node was positive, and then other mediastinal were negative. So usually you would do, like, I could go back, you would do in this case chemotherapy, because it's like a high disease stage. I agree with you that some cases you could do radiation, but if the board, this is literally a tricky question, I have to tell you this, you're right, you could do, but if I want to go back and show you something, most of the time, chemo is preferred if you do it, and then a radiation. So if you have those 2 choices, pick the chemotherapy. But if it gives you a choice with chemo and radiation therapy, pick the both. But the bottom line is everyone who has a high stage gets a chemotherapy after the surgery, because it's just there is things left in there. If you have is two choices, but you're totally right. It's a little bit tricky question, but yes, pick the chemo. But if it has both choices, do both. I don't think I will continue the head and neck. We have 5 minutes left. If you guys have question, I'm happy to answer within 5 minutes.
Thank you so much, Lila. That was very helpful.
Sure. Yeah. If whatever
things that you mentioned are mentioned in the U world, because I was doing the heme on Q world questions, and a lot of this, like
right. I don't say anything that is out of.
Yeah, it's
I realize that people don't want to listen to that.
Lilith, I have a question out of the topic. What are you guys doing about giving the COVID vaccine to patients who are on immunotherapy or patients who we can give?
Yes, you just have to space them out like a big vaccine and the immunotherapy, but you can get. One would imagine you would get more exaggerated effect. Like I have not heard from patients yet because we're just starting. But yes, you give them vaccine and then you spread like a timeline of it.
Okay, thank you.
So I have a question about the immunotherapy. Are the side effects that arises with the immunotherapy, are they a good sign that the tumor is actually responding and the body is actually responding to the tumor? Does it have any correlation with the response to the tumor or not?
Very good question. So some of them does, like for example, a rash, specific type of a rash, like bullous rash, does have correlation, but not always. And one other thing I would like to tell you, that a lot of times you give someone immunotherapy, one dose, and then patient develops a side effect, but you can no longer treat the like a really great side effect. What you really do, you watch those patients. You don't have to change your therapy just because you are not able to complete X amount of the drug to your patient, because you can still see an effect even giving it one dose and then seeing the rest of the effect. So the answer to your question will be yes for some of those, but not all. For example, if patient develops hypo or hyperthyroidism, or that's not that I've heard, but skin, and this is to refer to this one. I think the ones that have more of a lymphocytic origin or innate lymphoid mechanisms, you would see more rather than was have like antibody mediated. So some of them yes, some of them no. But the bottom line is, even if your patient develops side effect, you discontinue the immunotherapy, you do not have to start the next line of therapy. Your patient might continue. So you can tell your patient is at the hospital, developed the colitis, patient is on immunotherapy, very stressed about that. I will not be able to continue immunotherapy. Number one, you can still re-challenge if you need that. But number two, you can tell your patients that even they will receive one dose of immunotherapy, you can still continue to respond to the treatment.
I have a question. So I see in the side effects there's like hyperthyroidism, neuropathy. Are these side effects usually reversible after you stop the the immunotherapy, or
Very good question. So hyperthyroidism, no. Adrenal insufficiency, no. Some of them remain on a thyroid hormone or physiological adrenal doses replacement, steroid replacement. Others can be reversible. That's yes, like pneumonitis or arthralgias with the steroids, cane ones. Some of them remain like endocrine ones.
I'm not sure if you talk about timing. Do we expect those side effects right after or at any point of treatment?
So the timing can be any time. Remember, I told your patient, it can start from week 1. It can be like some of them, like hypophysitis, can happen like later, week 6, liver like a week 4, but anytime. As a general knowledge, do not ever be surprised, even if you stop the drug. Just remember, someone comes to you, stop the drug a month ago, because remember, these are monoclonal antibodies. These are not chemotherapies with half-life of like 12 hours. These drugs stay in your body like weeks.
from all
You
these
get a
side
drug
effects,
like every 6 weeks. I'm sorry?
No, sorry. I'm sorry. I interrupted you.
No, you're fine. So patients get this drug like pembrolizumab every 6 weeks. Remember, it stays in your body 6 weeks, so it can still have a side effect for quite amount of time.
And from all these side effects, which are the most common side effects that you see in clinical practice?
Skin one is very common, endocrine ones are really common. It follows by a lung, like a pneumonitis, and then GI. GI is more common with the ipilimumab, anti-CTLA-4 one. If someone is on ipilimumab, have a high suspicion. You can see a lot of arthralgias now, patient respond, and then followed by transaminitis. If I would have to pick 5 of them, I would pick skin, endocrine, liver, lung, and GI. Which one is really fatal is the cardiac one, which is unrecognized. Sometimes people even not think about that, but this can be. I have seen a patient who died from myocarditis. Hello?
So it's out of the lecture. So me and a lot of other residents are planning to apply for Hem-Onc fellowship next year.
Mm-hmm.
So it would be really interesting to hear like your tips and the tricks for.
Absolutely. We can set up a time. It will be good for me in March. It will be good in June, May. So one of those months we could definitely do it. Absolutely.
Perfect. Okay. Okay. Sounds good. Yeah, I will reach out to you and we can arrange this later.
Yeah.
Thank you.
Thank you very much.
So Abdullah has my slides. I have some head and neck here, so you guys can